fine. So, okay, I think start today's discussion on anorectal manometry. So anorectal sensory motor function can be assessed mainly by anorectal manometry, rectal sensory tests, and also a balloon expulsion test. There's a series of measurements that would describe the voluntary and also the involuntary control of the anal canal, the rectal-anal coordination, evacuatory functions of the anal canal, and also rectal sensation. So among the indications for an anorectal manometry include patients with constipation or evacuation disorders, fecal incontinence, symptoms where they have functional anorectal pain, or in conditions when the patient has symptoms to suggest hyper or hyposensitivity of the rectum. Besides that, pre-op and post-op assessment is also crucial. For example, pre-op assessments before fistulotomy or a lateral sphincterotomy. Post-op evaluation can be performed, especially in post-op cases that develop fecal incontinence or even in post-obstetric injury or post-traumatic delivery. So among the preparations required include they can continue on their routine medicines, no reason to stop them. The role of bowel prep is rather optional. It's best for the patient to open their bowels just before the procedure. If they have impacted stools before the procedure, then we can consider giving an enema to empty their bowels, and they will require a consent also. It's very important to perform a colorectal examination before the procedure. First and foremost, it provides an initial assessment of the pelvic floor structure and function and also the sensitivity. At the same time, we can also exclude for local pathology. For example, there's tenderness or even there's infected feces. At the same time, we can also explain to the patient what do we mean by squeeze and push that we will ask them to perform during the anorectal manometry. And at the same time, when the patient squeezes, we can assess the anal tone. And when the patient pushes, we can look for any signs of either a rectal seal or even a rectal collapse. So manometric sensors, they record the circumferential pressures that happens in the anal canal. The recommendations that are available now are based more on solid state manometry system. And at the same time, the catheters that they recommend are pin flexible catheters. There are other catheters, however, these are not standard. The position of the patient during the procedure should be in the left lateral position with the knees and hips in the flexed position. It's important to use a non-anesthetizing lubricant. At the same time, we need to ensure that the base of the rectal balloon is attached to the catheter at 3 to 5 centimeters above the upper border of the anal canal. This is very crucial to prevent the balloon from impinging on the anal canal during inflation because it will cause quite significant amount of pain. And the most distal recording sensor should be external to the anal perch. If at all during the procedure the patient develops any form of pain or discomfort, the probe should be immediately withdrawn. If on the second attempt there is still pain or discomfort, then we need to reassess the patient to identify why the pain is going on. Right, so briefly on rectal sensory test. The position again should be on the left lateral position. It's conducted with either the integrated balloon on the probe or a separate system. The balloon capacity usually is not less than 400 mils because some healthy volunteers, the upper limit is usually around 350 mils. And the balloon ideally should be latex free. Balloon distension can be done in two ways. One is a continuous ramp up insufflating the balloon. The other method is gradual distension of the balloon. If it's a ramping up of the balloon, it should be done at 1 to 5 mils per second. But if it's a basic dilatation, it should be done at about 10 mils per second. So yeah, with regards to balloon expulsion test, it's ideally performed using a flexible catheter up to 16 French in diameter. It's also a non-latex balloon placed at the tip of the catheter. A fixed volume of 50 ml of water is recommended. Again, the position is always on the left lateral position during the insertion, and after that, they are moved onto a commode in privacy during the procedure. The alternative tests for balloon expulsion tests include barium dactylography or even MR dactylography. So this is in fact the algorithm for a high resolution anorectal manometry. When upon insertion, there are steps to follow: stabilization for 3 minutes, then rest, and then there's short squeeze, endurance squeeze, cough, push, rectal sensory testing, and also balloon expulsion test. The RA can also be assessed during the sensory testing. Okay, this table in fact shows the overall summary steps that can be or that should be performed during the anorectal manometry procedure. So after insertion, we give a 3-minute off stabilization for the patient to get used to the catheter inside. This is crucial to allow the anal tone to return to the baseline after intubation. Sometimes we can also see some very ultra slowly, but rarely can be seen. After that, it's a rest period where we measure the resting pressure for 60 seconds. We need to tell the patient that they should be relaxed, remain calm and quiet, and do not move during this procedure. This will allow us to assess the basal anal tone during rest. After that, we ask the patient to squeeze 3 times. Each squeeze lasts for 5 seconds. And in between each squeeze, there will be a 30-second rest interval. So we choose the best squeeze out of the 3-4 analysis. This short squeeze in fact measures the anal pressure during voluntary effort to contract the anus. After that, we move on to the endurance squeeze or the long squeeze, where we ask the patient to squeeze for 30 seconds and after that a rest interval for 60 seconds. This reports the anal pressure during sustained voluntary effort for 30 seconds. After the long squeeze, we start the cough, or the alternative would be blowing a balloon. So we do this procedure twice, in between separated by a 30-second rest interval. It's important to make sure that if the patient is coughing or blowing, it has to be a single effort, not a double cough or a multiple cough, because it will affect the analysis. The best cough effort or a balloon blowing effort is used for analysis. So the significance of this test is because you will be able to assess the reflex increase in the anal sphincter function during a sudden change in the increment of the intra-abdominal pressure. Finally, after that, we go towards the push, where the patients are asked to push 3 times for 15 seconds each, and each of them are separated by a 30-second rest interval. The recommendation also say that we can include the rectal balloon insufflation to assist in the push. However, it's not really mandated. So the best out of the 3 attempts is used for analysis. The significance include it measures the anal and the rectal pressure changes during simulated defecation. Rare is usually can be assessed during rectal sensory testing, where we inflate the balloon and we can see the relaxation of the penis. So with regards to rectal sensory testing, there are several volumes that can be recorded. The first one will be the first constant sensation volume, then will be the desired to defecate volume, and the MTV, maximum tolerated volume. These will all be used to assess the degree of hyper or hyposensitivity in the patient. Balloon expulsion test, it measures the ability based on the time that the patient takes to expel the balloon from the rectum. These are in fact just a summary of the definition that has been in fact described earlier. So with regards to resting anal pressure, the resting anal pressure is maintained by IS, the internal anal sphincter. So any abnormality of the resting anal pressure will indicate there's some abnormality in the IS or the internal anal sphincter. The external anal sphincter and also the hemorrhoidal plexus may play a role in the RAP, in the resting anal pressure. However, the biggest role is contributed by the IAS. The increase in the resting anal pressure indicates spasm. Tends to happen with anal fissure and also anal pain. However, a decrease in the RAP or decrease in the resting anal pressure may happen with, for example, anal injury, either trauma or post-surgery, or in some situations, internal anal sphincter degeneration, for example, in multiparous ladies. Well, squeeze pressure, in fact, will voluntary squeeze is a voluntary squeeze to assess the voluntary contraction of the EAS. So if there is any form of abnormality in squeeze, it indicates abnormal external anal sphincter. So a decrease in the EAS may in fact indicate either the patient is not compliant or not following our instruction to squeeze, or in fact there might be a possibility of an actual sphincter weakness which may be caused by either a muscle or a nerve injury. So in cough reflex, it's a situation where when a patient coughs, there will be a sudden increase in the intra-abdominal pressure. And it happens as a reflex where the external anal sphincter constricts to prevent seepage or leakage of feces. So in a situation where there is a decrease in a squeeze pressure with a normal cough reflex, this might be due to an impact voluntary control of the external anal sphincter or a damage coming from above the sacral level of spinal cord. However, in patients with abnormal cough reflex, also with a decrease in squeeze pressure, the lesions might come from a level below the sacral level of spinal cord. In patients with abnormal cough reflex, but with a normal squeeze pressure, the lesions might most likely come from above the sacral level of spinal cord, because the pudendal nerve supplying the external anal sphincter comes from the sacral plexus. So in response to straining, variations can happen, especially in position. If the patient is positioned on the bed versus the former, the response to straining will be different. Type of catheter may also be affected, and some patients may feel uncomfortable straining because privacy issues. And again, balloon expulsion test, in fact, they will try to expel out the balloon that is either inflated with air or water. In patients with significant balloon expulsion test, it may reflect a predictive response towards biofeedback therapy. Rare, in fact, is an intrinsic reflex where there is a sudden rapid rectal distension leads to an IAS relaxation. It's usually absent in Hirschsprung's, some form of a quiet manometry neuropathy, and also in post-lobe and field resection, especially in cases of rectal CA. So the three parameters used in rectal sensation are FCS, DVDV, and also MPV. So rectal hypersensitivity indicates there is reduced volume to stimulate the patient in order to open his upper bowels. tends to happen in IBS and also may happen in proctitis. On the other hand, rectal hyposensitivity, where the patient requires much larger volume than usual to have the urge or to stimulate the urge to have a bowel movement. These tend to happen in constipation, but also in evacuation disorders, for example, due to a spinal cord injury. So the overall anorectal manometry is assessed and classified according to the London classification. So there are several parts in the London classification. It starts with disorders of rare, disorders of anal tone and contractility, disorders of anorectal coordination, and also disorders of rectal sensation. So all those metrics and parameters that we gather can be placed into the algorithm in the London classification, and from there we can come to a diagnosis. The first part, for example, if it assesses rare, if the rare is not elicited, then it's called rectal anal areflexia. And then moving on, in terms of disorders of anal tone and contractility. So over here, it will assess the anal resting pressure and the subsequent metrics. For example, if the anal resting pressure is above upper limit normal, the likely finding is anal hypertension. The common cause is, for example, chronic anal fissure, the Rectal ani syndrome, and also procalgia fugax. On the other hand, when the situation comes to anal resting pressure that is lower than the lower limit normal, and then over there we will need to assess the anal squeeze. And then if the anal squeeze pressure is again less than the lower limit normal, the likely etiology will be a combined anal hypotension and hypocontractility. On the other hand, if the anal squeeze pressure is not less than lower limit normal, then it will be anal hypotension with normal contractility. So usually we follow the algorithm to come to a diagnosis, and we merge the overall diagnosis. And over here, it assesses disorders of rectal anal coordination. Over here, it's the primary foci would be assessment of the balloon expulsion test. If the balloon expulsion test is abnormal, the subsequent matrix would be assessing the rectal pressure, whether there's increment or not during a push. And from there, we can derive all our other diagnoses based on the other parameters. And finally, is the disorders of rectal sensation. So using the sensory parameters that we obtained, NTD, DBD, and also FCSB, we can come to a diagnosis whether the patient has either a rectal hyposensitivity when 2 out of the 3 sensory parameters are above upper limit normal, or when the patient has rectal hypersensitivity when 1 or more of the sensory parameters are below lower limit normal, or when the patient is labeled as a borderline rectal hyposensitivity when 1 of the 3 sensory parameters are above upper limit. So in there's a thing called dysynergia. There are in fact 4 types of dysynergia. So in type 1 dysynergia, the patient will have a normal propulsive force. However, when the straining happens, there is a paradoxical increment in the anal sphincter pressure. In a normal patient, when the patient is pushing or straining, the anal sphincter is supposed to relax. In type 2, there is reduce in propulsive force, but there is a paradoxical increase in the anal sphincter pressure. In type 3, propulsive force is still normal, but there is inadequate or absent relaxation. In type 4, there is reduced propulsive force and there is also inadequate or absent relaxation of the anal canal. So these are among the normal values that we have for anorectal manometry, and male and female tend to have a slightly different type of normal values. I think that's all for